Hi, everyone. I am Dr. Ellen Hayes from Vios Fertility Institute in our Milwaukee region, and I am joined today by one of my favorite people and physician partners in St. Louis, Dr. Julie Rhee.
Hi, Julie. Thanks, Ellen, for having me today, or I guess we're doing this together, but it's
tag teaming.
Yeah, we don't get to be in the same office all the time. So
I know. I wish.
I know.
So today we are going to talk about secondary infertility, and I think it's an important topic. A lot of it is going to sound similar to primary infertility for all of you watching, viewing, but I think the importance of it is that less secondary infertility patients seek care. And we want to kind of dispel some of the myths about that, talk about the reasons for it, talk about when it's appropriate to be seen and so forth. So secondary infertility, as opposed to primary infertility when there has not been a successful pregnancy and delivery in the past, means that you have had a successful pregnancy and delivery, but then are having difficulty conceiving another successful pregnancy. So it's really fairly common. I've read estimates of 3 million people, maybe 30% of fertility cases are secondary. I don't know about you, Julie, but I feel like that's a woeful underestimation probably. Yeah. And maybe related to people not coming in to seek care right away for that. What percentage of your practice would you guess?
I feel myself echoing. Sorry.
You're good.
Yeah. So I agree with you, Ellen. I think that it is an underestimation only because I do think that it does sometimes take patients longer to seek care when they've had a successful pregnancy and a baby before. And, part of that can be just not knowing the reasons for potentially having secondary infertility, while sometimes the reason is also feeling bad because you already have a child, and perhaps it's patients feel like they should be grateful for the one child that they have, or some of it can also be denial to say it worked the first time, so there's really no reason why it shouldn't work the second time. If you would ask me, I would say anecdotally maybe probably about 20% of the patients we see have secondary infertility. But I do agree that it's probably higher than what's quoted because, that data is probably based on patients who actually seek care and diagnosis codes and things like that.
Yeah, I think secondary infertility is kind of uniquely frustrating just because if you haven't had difficulty conceiving before, it's shocking if you aren't getting pregnant the second time around or the third time around. And so I do think people delay seeing the doctor because they're hopeful that it will just happen. And you're totally right. I think people feel guilty or like they're not grateful for the child that they have, which is absolutely not the case. I mean, I think patients know what their ideal family size is and they should go for it. So don't let anyone say, oh, be grateful for the one that you have and keep you from getting the care that you need. The time to seek care from a professional is the same as primary infertility. So if you're less than 35 and have been trying for a year, or 35 and older and have been trying for 6 months, that's when it's appropriate to go in and see the doctor. You can start with your OB, or you can go right to a fertility specialist like Dr. Rhee or myself. So Julie, will you review maybe some female reasons for secondary infertility?
Yeah, absolutely. So I think the point here is that reasons for secondary infertility, there's a lot of overlap between primary and secondary infertility. Those reasons that oftentimes we hear about in women who have primary infertility, you can have those same reasons for secondary infertility as well. So I would say, probably one of the most important points is, by the time I always tell my patients, I say, family building goals are really important to think about because if you think about it, pregnancy itself is about a year, and then by the time everyone's sleeping again and you have a little bit of sanity back in your life, it's at least probably another year. And so you add that up and quickly it's 2 years that goes by, right? And so the other day, Vios Fertility, a couple of physicians, we did a webinar on ovarian aging. So what's really important is that there's, this concept of ovarian aging where women, as we know, are born with a certain number of eggs that we have in our ovaries until we reach menopause. And although we might feel, at age 32 versus age 35, you might feel very similar. Unfortunately, our ovaries kind of have their own agenda, and your eggs age, and the quality of those eggs diminishes with age as well. So what patients with secondary infertility don't realize is sometimes that age really does make a difference, even if it's been only 2 years or 3 years. When you talk about ovarian aging, we know that the egg quality and quantity diminish over time. So I would say that that's first and foremost, one reason why you can have secondary infertility. Another reason is, especially with the pressures of having a baby and taking care of a family, and if you have a career or work, with weight gain and stress, ovulation disorders, which are prevalent for primary infertility, are also, it's the same case for secondary infertility as well. In addition to that, anatomic reasons. So if a woman has had either a vaginal delivery or a C-section, one of the first things that we ask is, were there any complications with your pregnancy or any complications with the delivery? Because, for example, if you had a really long labor and let's say a patient had postpartum hemorrhage, and a retained placenta, something like that required extra uterine instrumentation, there is possibility that there could be uterine scarring. And so anatomic reasons still exist with secondary infertility as well. Other things that kind of go in the anatomic category is just polyps and fibroids and other uterine lesions that one can find, and we can find that by doing simply an ultrasound or a saline ultrasound in the office. And if a patient...
And those things might not have been there before, right? I mean, so that can be something that has developed in the interim that wasn't a problem the first time.
Yeah, absolutely. Yeah. And that's a good point, because what I tell patients is, sometimes, and Dr. Hayes will get into some of the male reasons for secondary infertility, but sometimes we'll also find that when we do a male workup, that the semen analysis shows that the sperm count is very low. And what I tell patients is, it really only takes one egg and one sperm. And it could have just been that although it feels like you got pregnant very easily with the first baby, it could have just been that, the stars were aligned and that one sperm, right? And so it could have been that at the time that you conceived your first baby, that perhaps the sperm count was already diminishing. So to Ellen's point, there are things that you may not have picked up initially when you got pregnant that may appear later on. And I think polyps and fibroids are, kind of some of the other anatomic factors. The other thing I wanted to mention is general health conditions. So as you get older, if you have, chronic illnesses that you see a primary care doctor for, such as thyroid disease or diabetes or autoimmune diseases, as that general health worsens, sometimes it'll be more difficult to conceive the second time around.
Yeah, I totally agree. And the same would apply, I think, to the male partner. If there's worsening of health conditions or newly diagnosed health conditions, and maybe they're on different medication than they were in the past, if you've developed a medical problem, diabetes, high blood pressure, things like that, and you're taking more medication than you were in the past, that can have an impact. In general, we usually think of women seeing a more rapid decline in their egg quality, mid to late 30s, definitely early 40s. For men, they will also experience a decline in sperm quality. It's unfairly shifted by about a decade for the most part. So more like mid to late 40s, definitely in the 50s, we start to see decrease in volume of semen and really decrease in all the parameters. So the concentration or count of sperm, the percentage of sperm that are motile, we see more abnormally shaped sperm in older men. And we also see more DNA fragmentation, and that means that there's been more oxidative stress or damage to the DNA that the sperm contains. So that can translate into sperm that don't fertilize the egg properly. So that can certainly be a contributing factor too. I think that an important thing to remember, and this can happen at any age, but definitely increases in frequency as men age, would be erectile dysfunction and ejaculatory dysfunction. And again, sometimes these are medication related, but sometimes they're stress related or for other reasons. And nonetheless, what can happen is it can really interfere with the ability to time intercourse properly if you're not able to have intercourse as frequently. So that's another thing to kind of factor in. And I'd also like to mention that, you know, in our society, there are now a lot of men that seek out help for what they're calling low T. And so men are being seen in droves in these clinics that specialize in supplementing testosterone because they kind of target it as the male menopause treatment for low energy, for all kinds of things. And testosterone, basically, when you take exogenous testosterone, it works like birth control in a man, and it will stop sperm production or drastically lower sperm count. And so it's important that if you have not completed your family, even if your partner is having difficulty with a lower testosterone level, that they seek care from a specialist that understands how to address that without putting them on testosterone per se, because that will knock out their sperm count. So yeah, I think that in general, it's kind of keeping in mind that time has passed and that health can change and that, you know, general health conditions can develop or worsen.
Mm-hmm. I would like to sort of add on that, Ellen, about the about men seeking medical care. I think one really important point here is also, you know, I'm sure you can speak to this as well, but, you know, if a patient does have a male partner and they come in to see us as a couple, you know, I can't tell you the number of times the male partner says, oh my gosh, like this, I haven't been to the doctor. So like, this is my first time being to the doctor's office since I was, you know, a teenager or whatnot, right?
Yeah, that is a great point.
Men tend to not seek medical care as much as women do, and it's a known fact. And so, you know, as reproductive endocrinologists, kind of another really important job that we have is, you know, when couples come seek care for infertility, it's sort of, for a lot of people, their entrance back into the medical field. And we sort of have that really important job and the opportunity to educate about chronic general health. And testosterone, you know, you bring up a really good example. I mean, it's all over the radio and commercials, and the number of people who say, number one, the number of people who don't mention that they're on testosterone. So I can't even tell you like the number of times you say, what medications are you on? And they don't list it. And
absolutely.
Are you on any hormone supplements? Are you on any testosterone? Oh yeah, by the way, I am. And then you do a semen analysis and you realize that there's no sperm there. And just an important point is that with testosterone use, although it does diminish sperm count and oftentimes completely wipes out sperm count, the sperm can return. And I've had patients where they've stopped the testosterone and then 6 months later, sperm returns to normal and they're able to conceive on their own. But then there's a handful of patients where they've been on testosterone for so long that, you know, that the sperm count never really returns to normal. So those are all really important points. But I do think that it's interesting because chronic medical problems, although most people may feel like they're healthy, you know, not having been to the doctor in a while and whatnot, what I do often see is that more commonly than not, when we actually take a medical history, there's a little bit more there than you would think.
Yeah, I think that's a fantastic point. I think you can call yourself healthy, but if you haven't had a medical visit in 10 years, I think you're kind of just guessing. Yeah, that's an excellent point.
And we do, you know, with the evaluations we do, it's pretty extensive, but I think one take-home point is that, you know, the evaluation cycle can be done pretty quickly. So within a month, you know, we can look at uterine cavity by doing an ultrasound, by doing a saline ultrasound where we put fluid into the uterine cavity and therefore it kind of opens the cavity up so we can make sure that there are no polyps or fibroids. We can do an evaluation of the tubes, semen analysis, and then the blood work actually really not only checks for fertility related hormones, but also you know, we do a complete blood count, a blood type, a complete metabolic panel. And sometimes those things can pick up on, you know, general medical conditions that that a patient may not
Definitely.
have, you know, like thyroid
Yeah,
disease.
I mean, I'm sure you've diagnosed plenty of cases of diabetes that patients were not aware of. I definitely have. So it is definitely a touch base. And because we do that general screening in addition to the specific fertility screening, we find things. We find things that can definitely have an impact.
Yeah, and sometimes we don't. So, you know, I would say, you know, even when patients come in for primary infertility evaluation, we talk about the fact that in a good percentage of cases, we actually won't find anything that's abnormal. So I think another good point is that for secondary infertility, it's the same. It might be unexplained, but that doesn't mean that because it's unexplained, you don't have the same treatment options that you do for primary infertility, which could be something as simple as giving ovulation induction medications and then helping time things where you have timed intercourse versus a intrauterine insemination or IUI versus IVF. So it's kind of a big spectrum, but you know, I think the take-home point here is that the evaluation cycle is really important because it can either pick up on some things that you might not have known about, or we might not find anything, but at the end of the day, you know, it might still be a nice segue into kind of looking into treatment options.
Right, right. I actually usually tell my patients when I do evaluation and we're kind of landing in that unexplained infertility category, I say that is a diagnosis. Unexplained infertility is a diagnosis and it's been studied. And so we have prognosis and pregnancy rates for couples or individuals with unexplained infertility. So don't be frustrated. It's still good information to rule out some of these other things. And I also like to add, you know, I mean, with secondary infertility, if you have a child at home and like you mentioned, work and stress and life just kind of getting in the way, one thing to maybe focus on your own is to just kind of see what kind of lifestyle you're leading now. Are you making sure you're getting sleep instead of staying on your device later than you need to or watching Netflix? Are you eating as healthy as you can? Obviously, nobody's perfect and we aren't either. But focusing on nutrition is really important too. Are you getting some exercise? Because moderate, regular exercise can improve fertility, both in the man and the woman. And just, you know, managing your stress, finding ways to manage stress can be really, really helpful too. It can bring down cortisol levels and all of that can have an impact on fertility. So just some lifestyle points that you can kind of ponder before you even see a fertility specialist.
Yeah, absolutely. I mean, I want to say that it is so hard to be aware of where you're at with with work-life balance or family, you know, life balance, all of those things, right? I mean, I struggle with that on a daily basis, and sometimes it
totally
takes that little bit of just stopping for a second to really think about it and be intentional about what you're doing. And I think, you know, you bring up a good point. You know, when I counsel my patients about lifestyle factors, I say and it sounds cliche, but I say take baby steps. You know, especially even when we talk about weight loss, you know, I'm not a huge proponent of patients doing these really extreme fad diets.
No, absolutely not.
If you put more, if anything that you're doing causes more stress, then that's almost counteracting, you know, the fact
any benefit you get from the weight loss itself.
Yeah, absolutely. Absolutely. So, you know, I think even with secondary infertility, seeking care, I think, you know, one other point is that maybe patients don't seek care as much for secondary infertility as well, because they're kind of afraid of what they might find. And I've also heard this from patients who have a first or second child and then are unable to conceive again, where they say I didn't come in for the longest time because it just, I didn't want to hear anything that was going to be too invasive or aggressive.
Right.
You know, it sounds scary because everything happened so naturally the first time. But I think a take-home point is, remember, we have a lot of different treatment options. And I think the most important thing is to also seek care from a physician that's going to listen to your story and, you know, really ask you kind of your journey and where you're coming from and how you feel. And so I think it's really important to be aligned in that way, but also for patients to know that it's not a scary thing just to seek care. And if you decide not to do anything after getting the evaluation, depending on your age, if you're like, you know, we're going to try on our own for another 3-4 months, that's okay too.
Yeah, absolutely. I think that's misconception that if you step through our door and see us, that we're going to find something really wrong and we're going to tell you you have to do IVF. And that is absolutely not the case for most couples. Most individuals and couples have choices, and we lay those out after we have the evaluation done and say, okay, here are your choices. What are you thinking? What approach do you want to take? Sometimes that's not the case in more extreme situations, but oftentimes it's more of a discussion. And sometimes what we land on is that they aren't interested in treatment, but they're happy to have that information to make that decision with. So they're not wondering. Yeah.
Mm-hmm.
So do we have any questions from the group? All right. How long do you try before seeing a fertility specialist for secondary infertility? Is the same like 6 months or 1 year for insurance purposes based on age? And definitely I would suggest to kind of follow those same guidelines, less than 35 years old, trying for a year, 35 or older, 6 months. Obviously, if there are known problems, if you already know that you're never having periods and not ovulating, or if you have reason to suspect that you have blocked fallopian tubes or fibroids or endometriosis, or that your partner might have a low sperm count, there's no reason to wait a full year or a full 6 months. You can really come in anytime and seek evaluation then. Mm-hmm. Anything to add to that? I think that's one of the ways that it really aligns with primary infertility. There's not a difference. You really can come in anytime and see us. You don't have to wait a full 12 months. A lot of people come in sooner. So feel free to just, touch base and say, is it appropriate for us to come in at this point?
And I think one of the easiest evaluation tools that we have that we can do at any age that might be, we always say knowledge is power. The more information you have about your body and your health is just ovarian reserve testing too. So we can check something as simple as an AMH, which is anti-Müllerian hormone it's a marker of ovarian reserve. It gives us an idea of your egg quantity at your age, so that if it's low and it's more concerning, then we can counsel you on that. But yeah, we have really easy evaluation tools that don't take a lot of time. So I would say ovarian reserve testing is something that you might want to pursue sooner than later. But I agree with Dr. Hayes that there really isn't a good time, but when you feel like, you're ready to.
Yeah. And we know nobody wants to have to come in and see us.
Right.
We know that, but we're nice and we'll take care of you.
Although, I will say patients usually have a hard time leaving.
That is so true. That's a good point. They're sad to go once they're pregnant.
A lot more personalized care.
Yeah, that is a very, very good point.
To our patients too, though.
All right, here's another question. Should I see my OBGYN or make an appointment with a fertility specialist? What do you say about that, Julie?
Yeah, I think you can go either way. If you have an OBGYN that you trust and that really well, I would say you can always start there and ask them their opinion. And OBGYNs are really great at what they do. They're all different though in terms of how much of your workup they will start. So if you want to just jump right in and do the complete evaluation, you can always just go ahead and make an appointment with one of our specialists.
Yeah, I agree. I think there are some OBGYNs that are very comfortable doing a thorough evaluation of both partners and even potentially initiating some, less aggressive types of fertility treatment. Others don't really feel comfortable doing maybe any of that. And so you have to ask your doctor what their comfort level is, what their experience is. But you definitely can't go wrong seeing a fertility specialist. So if you're kind of on the fence about that, I think the other thing I'll add about that is with the evaluation, you don't want to go to your OBGYN and just say, evaluate me if pregnancy is not happening. We like to do a complete evaluation of both partners because not only, do we often find a subtle issue with the female partner, but it can be both partners. And so we might be missing something that would be really important information for you to have while you're making your treatment choices if we piecemeal the evaluation like that.
Yeah, and Ellen, I'd like to add there, I think you can go either way, but I think do what feels right to you, because I've also had some patients who have said, I asked my general practitioner or OBGYN to evaluate me, and maybe they didn't know what that meant. And sometimes you'll find that you'll get an answer that you don't feel comfortable with, whether it's just keep trying. It'll happen. Try for another year. And if you feel uncomfortable with that answer, I would say then it's probably time to, seek an opinion of a fertility specialist.
Yeah. And if you've been trying that 6 to 12 month range and you do have an evaluation with your OBGYN and they don't find anything and say, well, it's unexplained, just keep trying on your own. That's not the answer you should be getting. That should prompt you to see a specialist, because it's still critical that we talk about different treatment options to expedite pregnancy while you're still in that window of time where we have an opportunity to do that.
Absolutely.
All right. Well, I think that's all the time that we have today. Thank you so much, Dr. Julie Rhee. It was fun discussing this with you. And if anyone watching has more questions or is interested in scheduling a visit, Vios Fertility Institute has offices in Milwaukee, Chicago, and St. Louis, where Dr. Rhee is located. Milwaukee is my location. You can reach out to us either by phone or at viosfertility.com to schedule a consultation or just to ask a question. Feel free to reach out for that too. But thanks for joining us today.
Yeah, thanks everyone. Thanks, Ellen.